Good afternoon, everyone, and welcome to the Henry Schein Dental Academy webinar series. My name is Adam, Marketing Specialist, and I'll be your moderator. We are excited to welcome Dr. Fiona Collins as our speaker tonight, as she will discuss best practices in instrument reprocessing. Dr. Collins is an international speaker, author, and expert in infection control and disease prevention. She is a member of the American Dental Association, the ADA representative to the Association for the Advancement of Medical Instrumentation, and a member of OSAP. Before we get started, we have a few reminders. At any point during tonight's webinar, we encourage your participation through the chat and Q&A features. Please type any questions you might have into the Q&A section of your control panel, and we'll answer them live at the end of the presentation. Henry Schein is not offering CE credit for viewing or attending this presentation live or on demand. And this webinar is sponsored by Tutenauer USA. Dr. Collins, welcome, and thanks for being with us tonight.
Thank you, Adam. So as Adam mentioned, we're going to talk about best practices in instrument reprocessing. We'll also be looking at some errors that can occur, looking at the interface of the IFU for the device that's being reprocessed and the reprocessing equipment. And then lastly, looking at the infection control coordinator. This presentation is based on information from current recommendations and regulations, as well as consensus standards from AAMI. Specifically ST79, which is the Comprehensive Guide to Steam Sterilization. The other organizations, obviously the Centers for Disease Control and Prevention, Dental Setting 2003 guidelines. And you can see here a tooth as well with the CTC logo on it. And this is actually a program that you can download onto your phone. And you can then use that. It's a summary of the guidelines rather than being a couple of hundred pages. It's all condensed down. So it's a very useful, basically, tool that will also give you links, URL links to specific sites for more information. The other ones you can see here are the Environmental Protection Agency, the FDA. And the reason I put the FDA up here is simply because many of the devices that are used in the sterilization process and other aspects of reprocessing are medical devices that are cleared by the Food and Drug Administration. The last one I have here is OSHA, Occupational Safety and Health Administration. And we will touch on that in specific areas when we're looking at reducing the risk of injury or parenteral damage. So as we look here on the left-hand side, we can see Spaulding's classification. And this obviously classifies instruments into critical, semi-critical, and non-critical. We're going to focus on instrument reprocessing that involves autoclaving, and well, obviously cleaning and autoclaving specifically. So that will be cleaning and heat sterilizing for the critical instruments, as well as heat-resistant semi-critical instruments and handpieces and other attachments. On the right-hand side, we can see a very brief summary of the different stages of reprocessing. It's essential to follow the device manufacturer's written instructions for use to ensure proper decontamination, in this case, sterilization, alternatively for non-critical disinfection of the device. We'll now briefly discuss personal protective equipment before looking at the protocols for instrument reprocessing. Of course, firstly, hand hygiene must be performed before donning and after doffing or removing PPE. Appropriate PPE must be worn in accordance with CDC recommendations and OSHA requirements. It must protect the operator's clothes, skin, and for the dental setting, we're interested in ocular, oral, and nasal mucosal protection from blood and other potentially infectious materials. You must wear heavy-duty utility gloves when there's a risk for sharps injury with exposure to blood or open. Wearing these heavy-duty gloves while handling contaminated items reduces the risk, the potential for puncture, it limits the amount of microbial burden on your hands, and it reduces the risk of cross-contamination. Gloves must also be chemical resistant when there's a risk of exposure to hazardous chemicals. Shoes should be closed, no open toes, and a waterproof apron may also be indicated to protect attire from splashes. So let's now look at the process from start to finish. The first thing is within the operatory, and ideally sharps will be disposed of in the operatory And by doing so, you're actually eliminating their presence during transportation to the reprocessing area, and therefore reducing the risk of percutaneous or sharps injury. Must be disposed of in puncture-resistant sharps containers that are OSHA compliant. It's important not to fill these containers beyond the fill line and to seal them when they're full. We can see here the single-use symbol, and single-use items, of course, must be disposed of. For many, this is also best done chairside and simple, particularly if they can go in the general trash. They may be single-use because of the inability to reprocess them or because of an inability to clean them. An example of difficulty, if not inability to clean them, would be high-volume evacuation tips. And if you think back to, very few offices use them now, but if you think back to the old metal reusable high-volume evacuation, you actually cannot clean inside that lumen thoroughly. And of course, if you can't clean properly, you cannot sterilize or disinfect, depending on what you're doing. Single-use items must not be reprocessed or reused. They have the single-use symbol. They do not have instructions for use for reprocessing. And in fact, any device that does not have reprocessing instructions is regarded as single-use. Point of use cleaning to remove gross soil should be performed as well in accordance with the device's instructions for use. Contaminated instruments should be transported to the reprocessing area or room as soon as possible. On this slide, in the upper left, we can see closed perforated cassettes containing contaminated instruments. Closed perforated cassettes in general offer several advantages, and they include improved inventory management, efficiency, and of course, a better level of safety. They should be locked closed for transportation. However, if you think about it, given that they're perforated, it is possible that the tip of a sharp instrument could stick through a perforation, risking a sharps injury. It is not only best practice to lock the cassette and then place it in a closed container with solid walls and a lid. It's actually part of OSHA requirements. OSHA requires that a puncture-resistant, leak-proof on the sides and the bottom, closable and labeled container be used for devices with edges or sharp points that could penetrate the container or skin. The container must also be labeled with a biohazard label. And here we can see an example, and you can see there's a cassette inside this tub. So this tub closes, the handle's closed tight. It is leak-proof. It's obviously puncture resistant as well. So this would be compliant in taking the closed perforated cassette to the reprocessing area or room. On the right-hand side, you can see what some people would call the Steri Center. And here you can see the sequence of equipment from, in this case, the right side to the left side. On the right side, you start with what you do on the arrival, which we'll cover in a moment, followed by cleaning, rinsing, and eventually sterilization. And we can see here that we've got a red light on the right-hand side and a blue light on the left-hand side. This is one of the easy ways to make sure that everybody knows as soon as they get to the Steri Center or to a reprocessing room, which end of the room is the dirty end and which end of the room is the clean end. It avoids confusion, it avoids recontaminating instruments that have been decontaminated and are then going to be packaged and sterilized. So this is actually a really important aspect. On arrival in the reprocessing area, now we'll discuss it, we would sort the instruments by category. If you have hinged instruments, the hinged instruments should be fully opened for further reprocessing. And if you have devices that should be disassembled in accordance with the instructions for use, then at this point, they should be disassembled. This is really important. If, for instance, forceps or orthodontic pliers are not fully opened, then the cleaning process will not be able to access those areas. And of course, those areas will then not be clean. In addition, sterilant, in this case steam, would also not be able to access the area. Now we can see here a tub and also a tray. The tray's got foam in it, the tub would have solution in it. And these are actually pre-soaking foam and pre-soaking solution. So this would be indicated provided it's in the instructions for use for that device, if it's going to be a while before the instruments will be further reprocessed. Ideally, they would be reprocessed shortly after arrival in the reprocessing area. But if this is not possible, then pre-soaking will actually help to prevent debris from drying on. If unfortunately, before the instruments reach the reprocessing area, debris had already dried on, then you would use the pre-soak solution or foam to help to moisten the debris so that it's easier to remove and in fact able to be removed during the cleaning process. There are many pre-soaking foams and solutions available. If you use an enzymatic, it will start to break down whichever substances there are enzymes for that breakdown process. If it's a full enzymatic, it will break down proteins, it will break down carbohydrates, and it will break down fats as well. So this is a very useful process, A, if it's dried on already, or B, if it's going to be a while before they're processed. If you use a foam, it's really important to make sure you put enough foam in the container so that once the air bubbles in the foam start dissipating, the foam still adequately covers those instruments. Best practice is to wipe off debris and other substances, such as cements and gross soil, while you're using the instruments in the operatory, for instance, by using gauze, before it has a chance to dry on. If there is gross soil present, first rinsing the instruments in cold water or immersing instruments in cold water with detergent and then rinsing them will help to remove some of the gross soil before the cleaning phase. As I've mentioned, thorough cleaning is absolutely essential prior to further reprocessing. Instrument washer disinfectors, and we can see two versions of the Tiva here, will actually automate and standardize cleaning and subsequent drying of instruments. They offer consistency, they offer efficiency, and they are also the safest method of cleaning. They remove the need to handle cassettes or instruments during cleaning and also during dry. Here we can see a typical process, and this one's from the IFU for the Tiva. We can see that there's a pre-wash with cold water removing dirt or soil. There's then the detergent phase, which is the washing with detergent phase. It's cleaning with demineralized water and is suitable pH neutral alkaline additives. It's important to only use the detergent that is recommended in the instructions for use of the device manufacturer IFU. After cleaning with detergent, the first rinse is performed to remove cleaning agent residues. A second rinse is required. The thermal disinfection phase is also valuable, and this occurs prior to drying and substantially reduces the microbial load on contaminated instruments. This is performed using water at a temperature in excess of 90 degrees Celsius. Following the thermal disinfection phase, hot air drying occurs. In contrast to other methods of cleaning, this means that the instruments are dry when they leave the instrument washer or instrument washer disinfector, again reducing handling. One of the myths around instrument washers or washers disinfectors is that it's never acceptable to clean handpieces in this manner. The reality is it depends on the handpiece instructions for use for reprocessing. If those instructions for reprocessing state that a handpiece may be cleaned in an instrument washer or washer disinfector, then it is safe to do so, making sure to place the handpiece attached to the irrigation adapter so that the lumen of the handpiece will also be cleaned. Digital logs can now also be generated, further automating the process. You may have heard of people saying that they had been told they could use a dishwasher, or they wanted to use a dishwasher because it was easy to obtain one and considerably less expensive. The problem with doing so is you are not then using an FDA-cleared medical device, which is what the CDC recommendations contain. Not only is it not a medically cleared device, it's an FDA-cleared medical device. It does not function in the same manner. It's not been tested for instruments. And in fact, there's a study that was published in the Irish Dental Journal where they carried out some research comparing instrument washers and instrument washers, disinfectors, and indeed the dishwashers did not remove the soil. Now let's look at ultrasonic cleaners, which are semi-automated. It's important always to use the containers for ultrasonic cleaners and not to have any instruments touching the base or the sides of the chamber. If you do so, it can damage the instruments, and it can also damage the surface of the base or the sides of the chamber of the ultrasonic cleaner. So it's important to always also place instrument cassettes in racks and any loose instruments in ultrasonic racks or in special containers, and you can see some examples here. Only the recommended ultrasonic cleaning solution should be used. It should be changed minimally daily and more often. If it starts to look contaminated, then it should be changed out then. When fresh ultrasonic cleaning solution is placed in the ultrasonic cleaner, it's really important to degas it. If you think about how an ultrasonic cleaner works, it has transducers in the base. The number depends on the size of the ultrasonic cleaner, but let's take the case where there's one on the left and one on the right in the base of that device. Those transducers cause cavitation, which creating bubbles, and then the bubbles implode, and the implosion of those microbubbles against the instruments is what cleans the debris off. If you use a detergent and not the recommended ultrasonic cleaning solution, that impedes bubble formation and also the implosion of those bubbles. So it's interfering and reducing the efficacy of the cleaning process. The purpose of degassing is when you place fresh solution in the ultrasonic cleaner, you're introducing larger gaseous bubbles. Those gaseous bubbles need to be removed because they also will interfere with cavitation and implosion of bubbles. So that's the reason for degassing. It can basically be performed in one of two ways. For some ultrasonic cleaners, there's a degas cycle, and you simply turn it to the degas cycle, and it performs the degassing. Other devices do not have a degas cycle. It's really no problem. All you need to know is how long it needs to be degassed and at what power level. That's in the instructions for use, and you simply do that. So it's a very straightforward process. Considerations in selecting a device include: what size is it? What volume is it? What's the power level? Does it provide evenness of cleaning activity? Easy drainage. It could be a built-in hose. Do you want a countertop? Do you want an under the counter? And you can see a countersunk one here. Reliability. You want the support of the company that's provided it. You want to make sure you've read the instructions for use, of course, before using it. So all of these are considerations in which type of ultrasonic cleaner you choose to have, and also which size, and that's important from a capacity. The other method is manual cleaning, and I did not create a separate section for that. It's the least safe option. If you're doing manual cleaning, obviously you hopefully have you should have your heavy-duty utility gloves on, but it's still the least safe option. Nothing's 100%. If you must do manual cleaning, it should be performed low in the sink, underwater if it's an immersible device, but certainly low in the sink, and with a brush, a long-handled brush. You can also use long-handled tongs to hold it, and that makes it safer than without the tongs. It's important never to use a wire brush when you're performing manual cleaning, even if it's spot cleaning, because that can actually destroy the surface and you lose the passivation between the surface and the underlying alloy. So never use a wire brush, and use a long-handled brush, and preferably also long-handled tongs. But in essence, manual cleaning is the least effective, and manual cleaning is also the least safe option, and discouraged unless you might have to do a little spot cleaning after ultrasonic cleaning, if there's just a couple of spots that won't come off that way. After cleaning, you need to inspect the instruments. Best practices are to use lighted or illumination to inspect them, so lighted inspection or illuminated inspection. And then to repeat the cleaning process if there's any residual debris. So if there's any, it has to go through that cleaning process again. We just talked about manual cleaning as a method for spot cleaning in isolated spots only. You want to inspect the instruments for damage. If they're damaged, they need to be discarded. And again, they must be clean before proceeding. They also have to be dried. So if you've performed ultrasonic cleaning or some manual cleaning, then you're going to have to dry the instruments after rinsing them. That provides another touch point, so another reason, particularly with manual cleaning, why it's not as safe. When you're drying, best practice is a non-linting cloth so that you're not leaving any lint or pieces on the instrument before it gets packaged and sterilized. Now let's look at testing. We can see several types of testing here. I think we're all familiar with the foil test. That is performed not to assess the efficacy of cleaning in and of itself. It determines the efficacy of the ultrasonic the activity of the ultrasonic. So that's one method. It's a little cumbersome. You need strips of adhesive tape. The typical recommendation is up to 9 strips, regular aluminum foil, not heavy-duty aluminum foil. And when you've constructed your foil test, it should not touch the base or the sides of the ultrasonic chamber. You would then run it and then bring it out, shake it, and examine the foil. If it's an even distribution of pitting, then you know that the transducers are working on both sides. If you only see pitting and some holes on one side of the foil, then you know that the transducer in that side is functioning normally, but the transducer on the other side is not. So there's a flaw, there's a defect now in the transducer. It's not as effective as it was. That would require looking at the ultrasonic cleaner and seeing whether it needs to be serviced or replaced. The alternative to the old-fashioned foil test, as I would call it, is another test which uses dyes. And you can see an example here. This is the Tutner dye test. When it's unprocessed, you can see it's a clear glass vial. It's got a reactive blue-colored solution, and you can see there are little glass beads all gathered at the bottom. You would then space them out in the ultrasonic cleaning rack at pre-designated distances. The distance is going to depend on the size of your ultrasonic cleaner, how wide and how long is that ultrasonic rack. You can find this in the instructions for use. And this is actually a similar device, but the test is actually one that's available in medical facilities through medical suppliers. So the Tutner one's obviously for dental as well. Unprocessed, it's blue. It then goes through the process, and the ultrasonic activity makes the glass beads move around. That vibration of the beads causes color changes, and it goes through from blue, as you can see, to a deepish green, a lighter green, then also almost a yellowish green. And if it has been processed with high cavitation energy, showing that the ultrasonic cleaner is functioning correctly, then it will turn a yellow color. So other than placing the beads in, or rather the vials inside the rack or on the rack, that's all you need to do other than examine them at the end after the ultrasonic cleaner has been run. So it's quick and it's easy. The other type of cleaning, the other type of testing is actually for the efficacy of cleaning for that cycle. And we can see a couple of examples on the left here. Let's look at the one that's blue and look at that one in particular. So in this case, this would be for an instrument washer disinfector. The blue area it's a substitute soil that's meant to mimic the soil that would be obtained during dental procedures. So it contains proteins, carbohydrates, fatty acids, and dyes, and the dyes are non-toxic. The indicator is placed in the instrument washer disinfector, and we're seeing the whole area of the, it's almost like cardboard here, but there's a sheath that goes over this, and the only area exposed really at that point is the dye itself. So what you want to do is have this and check it after the cycle. If all of the soil's been removed, the device is effectively cleaning. There are gradations are also categorized. There's a chart that you can look at. So the cleaning efficacy tests are recommended in guidelines. If it states in the device manufacturer's IFU that you should use these cleaning efficacy tests, then they should be used. And it should be performed in accordance with the instructions for use. Instructions for use may indicate daily testing, and some may indicate testing with each load. So again, follow whatever the IFU for your device states. Let's now turn to sterilization packaging. We're now assuming that our instruments and devices are clean and dry. It should be, again, only an FDA-cleared product. In fact, sterilization packaging is a medical device. It should be strong to avoid damage to it, but also allow full penetration of the sterilant. It also verifies sterilization parameters when you use indicators, chemical indicators, and we'll look at that in a moment. It's specific to the sterilization process. So for instance, if you were to use sterilization packaging that's intended for an autoclave and instead use it in a hot air oven, in particular, paper plastic pouches are going to melt. So it needs to be FDA cleared for the type of sterilization device that you're using. Using chemical indicators is necessary, and it also avoids confusion between processed and unprocessed packages. Provided the packaging is intact and dry when it leaves the sterilizer, the instruments will remain sterile inside the pack until the pack is opened. If you're using paper plastic pouches, I very often have the question, should it be paper side up or paper side down? The answer is really look at what it states in the IFU or the instructions for use for that autoclave. Best practices in accordance with AMI are that these paper plastic pouches should stand on their edge in relation to the shelf. And the paper side of one pouch should be adjacent to, obviously not touching, but adjacent to the plastic side of the next pouch, so alternate surfaces. Some of you may have used cloth or woven cloth pouches or wrap instead. While these are considered to be green, they actually only work for a given number of cycles. So it's important if you're using those to understand how many cycles this is good for and then to replace it. The other aspect of green, if you're wanting to be green with paper plastic pouches, you can actually separate the paper from the plastic when you open the packages to release instruments for use. And those can be stored separately and they can be recycled. You have to have labeling. In the case of the cassette wrap or the sterilization wrap, it would be on the indicator tape. In the case of paper plastic pouches, it will be on the non-porous side of the paper plastic pouch. It obviously has to be visible and legible. And logically, it also has to be non-toxic, non-running ink. You would place the date processed on this, the sterilizer that was used, the cycle, and the load number. You would want a description of the contents. Now, this may be obvious with a paper plastic pouch, but it's not obvious with a cassette in sterilization wrap. You may be asking, well, do I really need to put every single instrument down on that list of contents? If you have a standardized list for instance, a restorative procedure or a scaling and root planing procedure, for instance, then if you have a standard list, you could put down sterilization of whichever of those setups it was. So that's one way around having to have a long list of instruments. You could put what the type of procedure was and separately have a standard list that people can refer to. You'd also want to identify the operator responsible for preparation and packaging. So now let's look at autoclaving. We can see here examples in a table, and I'm not going to read this table, but obviously different types of autoclave include gravity displacement, dynamic air removal, the steam flush pressure pulse, which is also a subset of dynamic air removal autoclaves, and pre and post vacuum autoclaves. So the main differences between these are how the air is removed, how effectively the air is removed. In the case of the pre and post vacuum, there's also a post vacuum drying phase, and the cycle times differ. So if we look at the gravity displacement, this removes air logically with the help of gravity. Once pure steam flows through the drain valve, it closes, and that allows the required pressure to be reached. At the end of the cycle, the valve opens, releasing steam and condensate. This is actually, as I mentioned, little less effective than dynamic air removal, and it's considered to remove about 90% of the air. In contrast to dynamic air removal, will remove 99%. So there's quite a difference, and it removes it using a vacuum pump during the pre-sterilization phase. Again, the device needs to be used in accordance with the instructions provided by both the sterilizer manufacturer and the IFU for the instrument manufacturer that's being reprocessed. Now let's look at the cycle times. We can see there's quite a difference. Oftentimes they'll give you the cycle time for the actual sterilization, and then you have to add on the drying time, and it will tell you what the drying time would be. So we can see from this, without reading everything, that the gravity displacement takes longer, and at a higher temperature, they're all quicker than they are at a slightly lower temperature. So again, effective air removal with most effective with everything other than the gravity displacement, and the pre and post vacuum also a post drying phase. We can see a couple of examples here, and the one in the lower right is actually it's quite innovative. This is a Trutnar one, and it's called the TH10. It can be used as either a gravity displacement autoclave, or it can be upgraded to a pre and post vacuum autoclave. So you can purchase this one, and then you can say, well, I'm only going to use gravity displacement. But if you change your mind and you want to upgrade, you can without changing the device. So you're not having to replace the device. You simply upgrade and use it with a pre and post vacuum phase instead. That could also be advantageous where regulations to change and recommendations to change, requiring a vacuum style autoclave for certain devices. The recommended cycle should always be followed for a device being reprocessed. Packs must be completely dry when removed from the autoclave, as they're otherwise subject to wicking once removed from the autoclave. This is the same we're familiar with when a mask is damp. When packs wick, microbes can pass through the sterilization packaging, causing the instruments inside the packs to be subject to recontamination. Cycles should never be interrupted. And make sure to check packs when you remove them from the autoclave for damage, identification, moisture, and visual change in colour for the internal indicator if visible, or external indicator if this was needed. Immediate use steam sterilisation or flash sterilisation should only be performed in certain urgent clinical situations. In many disciplines, it's not permitted at all, and while it still is permitted in the dental setting, it is strongly discouraged and does not follow best practices as it exposes instruments to recontamination once they leave the autoclave. Flash sterilisation should never be used for convenience or as a substitute for having enough instruments. Here we can see a tray with 5 mirrors. Clearly, they were not processed as an emergency, and this example does not represent an urgent situation or permissible use of immediate use steam sterilisation. If you do need to use this method, it should only occur as close as possible to the point of use, and the instrument should be used immediately. Implantable devices should never be processed using immediate use steam sterilisation. There's confusion about the terminology implantable device, and I've been asked questions on this in the past regarding dental implants. This does not include dental implants. They're delivered sterile, having been sterilised by the manufacturer using gamma irradiation and contained in vials. If you were to remove a dental implant from its vials, the implant is then subject to contamination. And if you try to autoclave it, you can damage the surface of the implant. Dental implants should never be sterilised in the dental setting. Now let's look at sterilisation monitoring. And we can see a few examples here. The top two are actually the mechanical, what's actually digital in most cases now, monitoring phase. On the top left, we can see an old-fashioned analog one. They work fine, there's no problem with them, but it is the older version. And it will give you dials that you can look at or displays that you can look at for time, temperature, and pressure, the parameters that we're interested in sterilisation. On the right-hand side, we can see an example of a digital one, and it very clearly gives you the temperature, as well as the drying time, the sterility time, what the chamber temperature was in real-time values, and the pressure. So it really gives you everything all-in-one, easy-to-read digital display. The other aspects of sterilized monitoring are the chemical indicators and obviously the biological indicators that we typically refer to as spore tests. So let's look at these again. I'd mentioned the mechanical indicators for time, temperature, and pressure. Now let's look a little more closely at the chemical indicators. Chemical indicators change color if the sterilization process is functioning properly and they are exposed to it. They do not assure sterility. The external indicator is a type 1, and that's required if the internal indicator is not visible. An internal indicator is always required. If you can see it clearly through a paper plastic pouch, then you don't also have to use an external indicator. But if you cannot see it through the pouch, and you certainly never can see it through sterilization wrap, then you must also use an external indicator. The type 2 biodic test is only used first thing each day for dynamic air removal sterilizers to check that they're functioning properly. The type 3 internal indicator only reacts to one variable, and the type 4 reacts to 2 or more variables at a stated value. The majority of type 4s on the market react to all 3 variables at this point. The type 5 and the type 6 are a little different, so let's look at those briefly. The type 5 is also known as an integrating indicator, and we can see a couple of examples here. As the name suggests, it integrates all parameters, so time, temperature, and pressure. It's reliable, it's tested. You would place one in the middle of the load at least daily, process the load, and then look at the indicator. If you look at the one above the Tutner one, you can see it's got a reject area and an accept area. So the bar darkens and it must reach the accept zone for it to have passed. Again, it doesn't replace spore testing. A type 6 is known as an emulating indicator. That integrates all parameters at a stated values from critical values for that particular cycle. And this is the information on this can be found in the ANSI AME 11141 standard if you're interested. There's also information on all of these in the ST79 consensus standard that I had mentioned at the beginning of the presentation. They're also known as cycle verification indicators. If chemical indicators do not fully change color, then the instruments need to be reprocessed. It's an indication that the process did not work properly. The last one is biological indicators or spore test. And these are the only indicators that can actually assure sterility. They consist of resistant spores. In the case of an autoclave, it would be Geobacillus thearmophilus. I always have difficulty with that, excuse me. And basically, you're measuring the microbial killing power of the sterilization process. The reason you're using spore tests is if you think about the chart that you would see for EPA registered hospital level disinfectants, you will see the chart on what resists which levels of disinfection. And if you recall, the spores are the most resistant microorganisms. So by using the most resistant microorganisms, in other words, spores, means if the microbial killing power can work for those resistant spores, it works for the less resistant microorganisms. In accordance with the CDC recommendations, this should be performed at least weekly for each sterilizer being used. It may be suggested that they are used more frequently, daily, as a best practice. If there's high sterilizer usage, more frequent spore testing should occur. A spore test should also be used each time with an implantable device. Options for spore testing include in-office testing, which is quick and gives rapid results to obtain information for sterility assurance. The alternative is mail-in testing, laboratory testing, which provides third-party verification. Considerations include ease of use, interpretation and documentation, desire for quick results, or third-party verification. In-office tests are rapid, and the one on the left here is the fastest one available. Spore tests are suitable and required for all autoclaves, gravity and vacuum autoclaves. For the in-office test, one vial is used as the test, and a second vial is used as the control from the same lot. When the spore test is completed, you want to find that the spores in the test vial were killed. However, if the spores in the control vial are also killed, the test has failed, as the control vial was not exposed to the process, which means the spores are defective. For the spore test, once the autoclave cycle is completed, the test vial is removed from the autoclave. The test and control vials are then crushed before being placed in the incubator and incubated in accordance with the IFU. What if a spore test fails? What's best practice? And why did it happen? If the spore test fails, a second spore test should be performed. If this one passes, the load may be released. The most conservative approach is to reprocess the load after a single failed spore test. Following the second spore test, if this fails, the autoclave must be removed from service and serviced or replaced. When these spore tests fail, all loads autoclaved since the last passing spore test must be reprocessed. This means from the start, including cleaning and autoclaving. In the case of implantable devices, these should always be reprocessed after a single failed spore test. The need to know which loads were processed after the last or previous passing spore test is a main reason for the monitoring log and essential to determine which loads were processed since the last passing spore test. In addition, if the autoclave is serviced, 3 spore tests are run in an empty autoclave, and only if all 3 pass can the autoclave be returned to service. For vacuum autoclaves, the Bowie-Dick test must also be performed. So let's look at that monitoring log and then why it might happen. If you've more than one sterilizer, you're going to have to differentiate your sterilizer's serial number and model. Sterilization date and cycle, the load number, the duration and temperature of the cycle, and the contents. And we talked about those already. So you would make a note of those in the monitoring log. You'd record the results of mechanical and chemical indicators. And for those that have charts, readings, and printouts, you would put those in the records. You'd also put the results of biological monitoring or spore tests in the log as well. Any maintenance that's performed on the sterilization device or autoclave should also be entered in the log. Repairs should be monitored in the monitoring log. And the other thing I should mention is that if the spore test fails twice after being removed from service, the autoclave either needs to be serviced until it's functioning again properly, or it needs to be discarded and a new one purchased. If it is serviced and passes, then you would need to run tests 3 times and make sure that the tests pass. You would also have to run the Bowie-Dick test in the case of the pre-vacuum autoclaves that we discussed earlier. When we look at this and we look at the monitoring logs, I'd mentioned you can have printouts, and I'd mentioned you can have data logs, and you can have downloads through a USB port. You can also have digital logs that can be transferred with Bluetooth. So the AMI, or the Association for the Advancement of Medical Instrumentation, recommends using sterilizers with recording devices or sterilizers with accessory recording devices or printouts, such as digital data loggers. AMI recommends against any type of autoclave that does not include one of those types of logging. Audits and records, you would need to place in the records validation of all equipment, certification, all testing performed, cycles performed, again, maintenance and service, a date and signature, and keep hard copy records with the logbooks. So now let's turn back to spore tests. Why might they fail? Maybe the sterilizer was overloaded or incorrectly loaded. I think it's human nature. We all tend to think automatically, well, there must be something wrong with the autoclave. It's human nature. But in fact, in very few cases, is it through any defect or damage to an autoclave. It is by far and large mostly due to an error of one sort or another in either what the spore test constituted or in how the spore test was performed. So in the case of an overloaded or incorrectly loaded sterilizer, the sterilant can't reach the spore test properly. If you think back to when we were looking at the sterilization packaging, I had shown an accessory basically where all of the paper plastic pouches were in a rack. By using a rack like that for paper plastic pouches, and you saw also that they were following best practices in being slightly up, well, they weren't absolutely vertical, but slightly off vertical, and they were arranged plastic to paper of the next one in sequence, obviously not touching. So by using racks like this or a single rack for a single cassette, you're spacing them out correctly so that the sterilant, in this case steam, can reach all areas and penetrate through the sterilization packaging. So if they're all jammed tight, packed together, and I think we've all seen it at one point or another, then the sterilant won't reach the spore test either. It could have been the incorrect time, temperature, or pressure for a number of reasons. Maybe the cycle was manipulated or interrupted. In fact, many autoclaves no longer permit manipulation or interruption of a cycle, which is a good thing. It could be improper packaging of the contents. That could cause failed tests. Failure to preheat the sterilizer, if indicated, inadequate maintenance, and obviously equipment failure is possible. So now let's look at improper packaging and why that might cause sterilization to fail. We're now looking at errors in sterilization and packaging rather than the spore tests. Well, again, if you overfill containers, all of the instruments are going to be jammed together. And even if the sterilant does fully penetrate the packaging, it won't fully reach all areas of the instruments. And that means those particular areas of the instruments could not be rendered sterile because the sterilant couldn't reach them. The pouches might be too small, so you've jammed instruments in. If you fold a pouch, that's considered improper packaging too. As I'd mentioned, the paper plastic pouches, and for that matter, sterilization wrap, are FDA-cleared medical devices. They are tested to make sure that they perform as they're intended to perform, and that the sterilant fully penetrates them as intended. If you fold a pouch, it means there's a double layer to go through, and they haven't been tested for that, and the sterilant may or may not go through. Incorrectly double pouching would have a similar result. Improperly double wrapping would have a similar result. And the material you're using may not be indicated. So you may be using a sterilization wrap that's not indicated, and it may be too thick. Peel pouches need to be stored in a cool, dry place. If not, they can become damaged as well, not allowing penetration of the sterilant. The other thing is all of these are single-use devices. So the packaging, once it's been used, with the sole exception of the cloth woven packaging or wrap, that can only be used several times, the rest is single-use and must be discarded after a single use. If you reuse it, who's to say how much of that sterilant goes through or not? It's not been tested in that manner, and you're also using it in a manner inconsistent with the labeling. Other errors that can occur that can compromise the sterilization process include having a gasket that's contaminated or damaged, improper air removal, failure to perform or check the biodix test for a pre-vacuum autoclave, which is used to make sure it's functioning correctly, filters that are clogged, steam traps that are ineffective, pressure gauges that are not well calibrated. Obviously, a water reservoir that's empty, if you're using a tabletop with a water reservoir, you need that water for the production of steam. So if it's empty, you're not going to get steam created. Or if it's nearly empty, insufficient steam. Perhaps the cycle was interrupted because there was something happening at the power point. Or you use tap water when in fact a specific water quality was recommended in the instructions for use for the device. So let's look at the gasket. The care of the gasket should be performed daily. You should clean the door gasket and the outside rim of the chamber. You can use mild detergent, water, a soft cloth, and a soft cloth or sponge. Again, look at the IFU and see what the manufacturer is recommending. It's important to clean the inside and the outside of the gasket flap, and also to check it regularly. If it's worn or cracked, then it will not function correctly, and it will compromise reaching the desired parameters for that sterilization cycle. Then let's turn to the filters in the chamber. We talked about filters being clogged as well. So the filter should be replaced as indicated in the IFU, and it's important to check the drains and the traps and to clean them as recommended again in the IFU. Also to clean the chamber using the product that the manufacturer indicates, and again, check the gasket regularly and replace when worn. So now let's turn briefly to learnings from the instructions for use. Well, if you look at some of them, the very first thing they say is read the operating instructions carefully before beginning any operation on the autoclave. So if we look at the IFU for the autoclaves, what information is contained in there? Well, obviously the operating instructions, the safety instructions, which are also critical, what validation and testing should be performed, what cycles have been validated. So for instance, you may see 4 pre-programmed cycles with different parameters that have been validated and can be used with that autoclave. How to avoid damage. And in fact, many IFUs will contain troubleshooting if you're having some difficulties with the autoclave or with the sterilization process on what might be going wrong and how you might be able to correct it if it's something simple. Obviously, if it's something more complicated, then it will need to be serviced. It will give you symbols, and we can see a couple here. And the digital symbols are typically self-evident. So in this case, on the upper one, we can see there's an arrow going from the water, and that actually displayed when the wastewater reservoir is full. There's another one that looks somewhat similar with an arrow going in, and that displays when you need to be adding the desired water quality water into the reservoir. So there are many symbols, and they're all explained easily, so there's no double guessing if you've read them in the IFU. It also explains how to avoid damage to the autoclave. It will give you tips. It will give you all of the symbols will be there. So and it will tell you about the warranty. So there's a lot of information in that IFU on how to use and operate the autoclave safely and successfully. So we've discussed the IFUs a number of times. It really is essential to read and understand them. Critically, it's important to know for both the instrument or device being processed, how the device is to be handled, and how the reprocessing equipment is properly used. The importance is demonstrated by the fact that manufacturers are now obligated by the Food and Drug Administration to have validated reprocessing instructions for use for operators. So now let's look at what we can learn from the other side of things, from the devices. So if you look at a given device, there can be different cleaning requirements depending on what brand and what model it is. So even within a brand, and for a similar type of device, it can be very different. Different sterilization parameters, what's the time, temperature, and pressure that's required, differing maintenance requirements. And then we come to the tricky situation where the required sterilization parameters are not a match. So you get a mismatch for the device and the sterilizer. So that highlights the importance of actually understanding the instructions for use before you purchase the equipment, rather than first purchasing the equipment and then making the distasteful discovery that the device you purchased can't be properly sterilized in the autoclave or autoclaves that you have. So you would want to read the IFUs. Let's say you're going to purchase some particular device. You want to read the IFUs, see what the parameters are and what cycles required, and then check your autoclave that you have that cycle available. If you do not, then either you're trying to program a cycle that you cannot program, or you're using an incorrect cycle to sterilize that device. If you're doing that, you're not using the instructions for reprocessing for the device. The other aspect of this is that you cannot then be assured that you are performing effective and safe reprocessing. You may, in fact, also be damaging the devices. And the other thing is that if you have a mismatch and you're using an autoclave to sterilize instruments or devices that require a program that is not available on that autoclave, then if you're audited, you will fail the audit. And that's actually one of the things that people have been dinged for when Joint Commission has gone into medical and dental offices, actually. So it really is important to understand that before you purchase the equipment rather than after. So considerations include make sure it's FDA cleared, fit for purpose. You want to understand the chamber capacity. Is it large enough? The alternative is actually to purchase two smaller autoclaves. That also means that if one is experiencing downtime because it needs to be serviced or replaced, that you don't have to wait and you haven't got loads stacking up while you're waiting for a loaner or a replacement. So by having two, you still have an autoclave that's running. It also means maybe one has different cycles or one different cycle and the others are the same. So that might help address the situation where the IFUs are a mismatch. You obviously want it to be easy to use. Fast cycles saves time and improves turnover. The range, the drying time. Does it have data lockers, printouts, tracking, or remote monitoring as recommended by Amy? Does it have advanced documentation and traceability options? Can you monitor it remotely? What are the maintenance requirements? And what's the company support? And are the manuals sufficiently operational? All of these are aspects of risk reduction. We talked about PPE, the way you work. So that in a sense is covered by how we discuss manual cleaning, avoiding it and then only using it with certain lengths of brushes and tongs, low in the sink and potentially immersed if that's an option for that device. Engineering controls, they isolate people from the hazard. So a really great example of an engineering control would be the instrument washer disinfectors we discussed. Substitution, you replace the hazard altogether. You replace the hazard, and then elimination, you physically remove it. So how do you leverage your infection control coordinator? If we think about everything that we've talked about, it becomes clear there are many things that infection control coordinator can streamline and help with. Obviously, it needs to be a designated competent person. It's frequently a dental assistant. It can be anyone else on the team. That person needs to be given the responsibility, but also the support to perform that function. So it needs to be built into the culture that that person has the support to do what he or she needs to do, and not just the responsibility. That person will contribute to risk reduction. They're responsible for training on infection control and OSHA required training. It doesn't mean they have to do it all themselves. They could be responsible for arranging it and somebody else comes in to do it. Or if they are trained in giving training and they have the knowledge base, they could do training themselves. They need to understand and be able to use the instructions for use. More importantly, they need to make sure and can make sure that the operator in the reprocessing area understands and uses the IFUs. One tip, since they vary a lot, is for the critical elements, there's often a list. You can actually take that list, print it out, laminate it, and keep it in the reprocessing room or area. And that really assists in helping to remind people or put key points up. The person can also be responsible for the written infection control policy that is required and the detailed plans. He or she can also lead in product considerations, and those considerations could be, are there other devices available that will increase safety? Another example would be what we just talked about, do the device and the autoclave parameters match for sterilization? Make sure that the products that are purchased and used meet standards and requirements. Responsible for arranging, validating, testing, and maintenance. The individual can also make sure that testing is being performed appropriately and logged properly, and perform almost like internal audits and monitor that people are doing all of these things consistently. And for instance, observational monitoring of correct use of personal protective equipment. So there are many, many tasks involved, but by doing all of this, you really can leverage that individual, make sure that everything is running smoothly, streamlined, all of the processes are being performed correctly, and that if you do internal audits as well, so kind of mock audits, then you can also catch things that would be caught in an audit or could be caught in an audit and then correct them. It doesn't necessarily mean that an official audit won't find anything, but it's much less likely to occur if you are taking corrective action along the way by performing internal audits, monitoring, and then correcting processes and, if necessary, retraining. So at best practices and protocols, you really need standardized, repeatable protocols, education and training. The products have to be reliable, efficient, effective, FDA cleared where required, and used properly. It's critical to adhere to OSHA regulations. They are mandates. They're not optional. and to use products in accordance with FDA regulations and EPA regulations. Sterilization monitoring in the manner we discussed is a best practice, required logs and documentation. So we really need to follow guidelines, best practices, and standards for safe and effective instrument reprocessing. So this was everything that I had in the presentation. We'll now turn to the questions and address those.
Great. Thank you for that excellent presentation. We've got a couple questions here. The first one is, how do you test the dishwasher?
How do you test? Well, you don't test a dishwasher because we shouldn't be using dishwashers. So I'm guessing the question is the instrument washer disinfector. So the test I showed tests the cleaning efficacy of an instrument washer disinfector. So the way I had described it is you place it in there, you run the cycle, you bring it out, you look at the dye, has it all been removed? And if it has all been removed, then this indicates efficient cleaning. The other thing you will receive when you're using an instrument washer disinfector, if you've got digital printouts or logs that you can download, then you can check the records, and they should be checked each time to make sure that everything was functioning normally.
Are there situations where the gravity displacement sterilization mechanism is better than using a pre or post vacuum mechanism?
As far as I'm aware, there are no situations where it is better. You have less effective air removal. It's a clear device and it's acceptable and it does a good job, but I'm not aware of any situation where it would be used deliberately instead of pre-vacuum.
What are some reasons for test failures for instrument washers?
If you didn't remove gross soil, if you use the wrong quality water, if you use the incorrect detergent, if you don't use the chemical that is recommended in the instructions for use, if you can manipulate the cycle, mostly you cannot anymore. But those are examples. If you've overloaded it, if you didn't load the instruments correctly, in the case of handpieces, the internal lumen would not be cleaned if you didn't place it on the irrigator system device. So it's like an adapter. So those are examples of why it may not function.
What are the new requirements for wash test indicators for instrument washers?
They're recommended, and if they're in the instructions for use for the manufacturer, then they should be used. And it is a best practice. Right. And it's recommended by Amy.
Let's see. What type of indicator is recommended for inside the pouches?
We discussed external and internal indicators. So in the case of internal indicators, we discussed types or classes 3, 4, 5, and 6, and all of those can be used inside the pouches. So typically, the majority of people would use a class 4, and most of them on the market check the parameters, time, temperature, and pressure. The only time you would use the external, as I've mentioned, is if you can't see the internal, either because it's in a difficult position within a paper plastic pouch, or because you use sterilization wrap or woven wrap or pouches, which you can't see through them.
And we had a couple people that were wondering if you could just quickly re-explain the degassing process.
Yes, sure. It's really very simple. You basically switch on, and I probably didn't explain it as clearly as I might. Basically, all you're trying to do is run the run the ultrasonic cleaner such that you're removing the large bubbles that are inherently in the fluid when you replace ultrasonic cleaning solution. So every time you put fresh ultrasonic cleaning solution in there, you're going to create large bubbles within it. It's inevitable. So you're basically simply running it to break up those large bubbles, and it's called degassing. And either it's an automated cycle that you just turn to where it says degas cycle on the dial, and then it will run, or you can find in the IFU, and you probably only need to find out once, and then you'll remember it, is which power level and for how long. So it's extremely simple, it's extremely straightforward, and it's also extremely important because if you have those large bubbles, then you cannot get effective cleaning within the ultrasonic cleaner. The other thing I didn't mention, I'd like to mention now, I don't think I did, was to make sure that the lid is on while the ultrasonic cleaner is running, because otherwise you're aerosolizing the ultrasonic cleaning solution and whatever is in it.
Where do you locate utility gloves safe for handling chemicals versus those used for handling instruments?
Well, in fact, the heavy-duty utility gloves are they're puncture resistant and they're chemical resistant. So for instance, the lilac ones that Q3D has, that's a good example of a heavy duty utility glove that is puncture resistant and chemical resistant. People have sometimes asked, can I use utility gloves that I would use in the kitchen? So they're not fit for purpose, they're not a device. And in addition, often they may be less puncture resistant, but they also typically have shorter cuffs. So you don't get the cuff up over the cuff of the gown or the clinical attire that you're wearing, which protects that from becoming wet and touching your skin wet.
And it looks like we have a comment here. We were told we must have, according to the CDC mandate, both internal indicator and external tape. Is that correct?
No, it's not correct. The CDC recommendations state that you must have an internal, that you should have and let me get back to mandate in a moment. You should use an internal indicator. And if the internal indicator is not visible, then you should also use an external indicator. Now, the question had the word mandate, so let me address that. The CD recommendations are exactly that, they're recommendations. However, if your state dental board promulgates the CDC recommendations, and the majority have, then they become regulations. And at that point, they're mandated. It's also possible that a facility can say, well, we know that that's what it says, and we know it's mandated because the state dental board has mandated it. However, we're also going to require in our policies that you use both every time. So there is that option, but it doesn't state in the CDC recommendation that you have to always use both.
Perfect. Thank you for clarifying that. We've got time for two more questions here. Do we need to worry about aerosols from ultrasonic cleaners in terms of COVID?
There isn't any evidence in terms of COVID-19 that it's aerosolized from it, but microbes can be aerosolized in general. It's not specific to COVID-19 if you leave the lid off. And for that matter, the ultrasonic cleaning solution in any case is aerosolized. So you're going to be breathing that in. And the surrounding areas can also become contaminated. So it wasn't specific to COVID-19. It was simple, and that's the first thing that jumps to all of our minds at the moment every time we hear the words. But it's really a general recommendation or requirement, depending on what was promulgated in the CDC recommendations, and it always has been.
All right, and our last question for the evening: what are the advantages of drying instruments after rinsing?
You actually need to dry the instruments after rinsing, because if you don't dry the instruments after rinsing, there are a few things that will happen. They're going into the packaging wet, which means you have a wet pack. If you have a wet pack, the autoclave drying cycle may not be able to compensate for it, which means the pack could be wet even after the drying cycle. And we discussed that if the pack is wet and it comes out the sterilizer, that it can wick and and the contents can become contaminated because the microbes can go through the wet packaging. So that was one reason for it. The other reason for it is if there are water droplets or small amounts of water, so it would be droplets, on the instruments because you rinse them but then didn't dry them, then those droplets can actually prevent the sterilant from penetrating the droplets and reaching the surface of the device.
Excellent. Well, thank you, Dr. Collins, for your time this evening, and thanks to Tutenauer for sponsoring tonight's webinar. If anyone does have additional questions about instrument reprocessing, please email us at webinars@henryschein.com, and we will get back to you with an answer shortly. Additionally, if anyone is interested in attending future Henry Schein webinars, visit henryscheindental.com/webinars for our upcoming schedule. As a thank you for attending tonight, everyone will receive the recording via email sometime in the next week. Thank you all again for joining us tonight, and we look forward to seeing you on future webinars.
And thank you to Tutenauer for sponsoring this.
Thank you. Have a great night.